Myopia in children might be grabbing all the headlines, but adults are also in the disease's crosshairs. Myopia can have a drastic effect on an adult's vision and quality of life too. So what to do? In a recent Cake magazine supplement, a consensus group of 11 world-renowned experts came together to frame the discussion on the current myopia correction landscape, including phakic IOLs. The consensus on selecting the most appropriate candidates for phakic IOL procedures was strong. 90% plus agreed that the degree of myopia, age, anterior chamber depth, and corneal health were the most important factors. Additionally, the stability of the candidate's refractive history was deemed critical.
So I think there's a number of factors to consider in deciding whether someone is better for laser vision correction or a phakic IOL when considering refractive surgery. The number one is really refractive error, because if somebody is over a -8, as long as they have a sufficient anterior chamber depth, I will very strongly recommend an ICL. And if the patient can't afford an ICL, I'll tell them, you know what, you should really save for that, because that's going to be better for you than doing a really high correction, laser vision correction like LASIK, because that can cause significant quality vision issues, higher order aberrations, and that's been well described in the literature.
So for me, any patient who's coming in for LASIK is considered for an ICL. We start off looking at all patients being considered for all options. Now, obviously, there are gates on that. I think for the most part for us, -6 is probably that sweet spot. So any patient who's myopic with astigmatism or just myopic, we basically look at for an ICL.
When patients have more than 6 diopters of myopia and they have a good, healthy eye where the ICL fits properly, for me it's a no-brainer, that's an ICL. In patients with less than 6 diopters and normal corneas, I do have perhaps a small preference at some point with LASIK, with femto LASIK. Today is very effective, but if there's anything, noisy cornea, thin cornea, some mild dry eye, anything affecting my decision-making process regarding a laser vision correction, I just jump naturally to ICL. So what's happening is that more and more I'm becoming more aggressive with ICL in lower myopes. I'm doing around 50 per month, and 20% of them are low myopia. So it's getting bigger and bigger, the number.
There are other factors that are important, obviously. So corneal topography, any pre-existing dry eye, the anterior chamber depth, we like it over 3, but really we routinely go down to 2.8, even in the US, and it's CE marked for that in Europe. Things like lifestyle, martial arts, or any hobbies that patients might have where there may be a concern for a flap, something like that, those all come into the conversation as well. And then really patient preference for visual recovery, procedure. Like if somebody's only a candidate for PRK and not a candidate for LASIK, then sometimes patients will choose not to do PRK because of the recovery process and might actually choose ICL instead, even in the lower diopter ranges.
Small decisions about refractive power can have an outsized impact on final results. When asked to prioritize the 6 most common methods of determining phakic IOL power, there was unanimous agreement that manifest refraction is the most important parameter, followed by true ACD, K1, and K2.
The most important thing that goes into the calculation of power is the refraction. So obviously you want a really good refraction, and there's a number of things that go into that. So we like to get a refraction, both a dry manifest refraction and a cycloplegic refraction, because most of these are younger patients, although we do some patients over 45. There's also really good reason to do a contact lens over refraction when we're getting over -6, 7 in that range, because vertex error comes into play, and that can cause level of inaccuracy in measuring refractive error in high myopes.
I do agree. I think obtaining an accurate refraction and max plussing patients is key to a good, successful outcome with EVO ICL.
The ICL, it has one of the big advantages is how predictable it is. We have 98% of our patients getting less than 0.5 diopters of refractive error. It's very predictable. The way we calculate is basically based in the refraction. Refraction is the most important measurement in these patients. And we do systematically a cycloplegic refraction, even though they are patients that are after their 40s and they have presbyopia. Sometimes there is a difference between cycloplegic and refractive. So it's very important to bear that in mind in order to plug in those numbers to the OCO system to get the calculation.
This video is just one part of our series looking at the guidelines on building proficiency in phakic IOL procedures. Scan the QR code below to access the entire supplement and learn about common practices from some of the world's best phakic IOL surgeons.